Okay, so let's start with number 111. An elderly patient has fallen and hit her head. You assess her level of consciousness as unresponsive using the AVPU scale. Your initial care should focus on what? D, airway, breathing, circulation. Super basic. Remember, level of consciousness is right up there with your ABCs in your initial assessment. Everything else comes later. Number 112. You respond to the home of a 59-year-old man who is unconscious, has slow, shallow breathing, and a weak pulse. The family states that the patient has terminal brain cancer and does not wish to be resuscitated. They further state that there is a do not resuscitate, a DNR, order for this patient. However, they are unable to locate it. What should you do? Yes, so the answer is A on this one. Good. Remember, when you've got a DNR on a patient, what has to be true for it to, for you to actually abide by it? It has to be present within 1 year. Yeah, so it has to be present. You have to be able to see it. It has to be timely. Usually they're year-long contracts, and you do have to renew them every year if it's a continual thing. They have to be valid in that they have to actually be signed. And they have to be for an out-of-hospital resuscitation or DNR attempt. So usually they're split up into in-hospital or out-of-hospital. We've talked about this. And you just have to make sure that they have an out-of-hospital DNR. So if they only had an in-hospital DNR, you could take it along with you, but you'd have to provide full treatment until you reach the hospital. And once you've completely transferred care over to the doctor and the nurses, they can stop care at that point if they have a working in-hospital DNR, but it won't apply for you as an ambulance, as a pre-hospital provider. So yeah, you'd begin treatment and contact medical control. In other words, you'd treat them exactly like a patient who didn't have a DNR, because for your legal purposes, he doesn't have a DNR. You haven't seen it, you don't know if it's valid.
And the patient can't sue or be treated?
No, because you're acting within the legal limits. Because if you didn't treat a patient who you were told had a DNR and maybe he didn't actually have a current one, then you'd be in major trouble and you would be liable for all kinds of things. Because that's negligence, that's your breach of your duty, like you had a duty to act and you didn't do it. They could sue you in civil court for not providing proper care. Yeah, that side of it, the negligence side, is a criminal thing. So the civil side would be they could sue you for however much money. The criminal side of it would be that you, the negligence, because you didn't act on your duty. So really big deal with DNRs. Definitely not something you're going to want to have to deal with a lot. And when you do, if you ever have to deal with one, you better know exactly the law surrounding it. And I mean, gosh, if nothing else, get a second opinion. If you're somehow confused, make sure your partner explains it to you. If they understand it better, call your medical control. If you're not really sure whether or not the DNR applies, better safe than sorry. But for the test, obviously, you need to make sure you understand when it's applicable and when it's not. Number 113. You are dispatched to a movie theater for a 39-year-old female with signs and symptoms of an allergic reaction. As you are assessing her, she pulls out an epinephrine auto-injector out of her purse and hands it to you. After administering 100% oxygen, what should you do? The answer is B. This one's pretty straightforward. Contact medical control before you give any drug. So A is definitely out of the question. And then C and D, should you do those things? Yes, but those are steps involved in actually administering a medication. You do want to verify its name. You want to check the drug's expiration date. You want to make sure you know the dosage. It's if y'all have seen in the hospital those signs, like the 6 rights of medication. It's like right name, right dosage, right date. There's all of them, and you don't really need to know all of them because you don't typically deal with them. But you do those after you contact medical control and get permission to give the drug. Number 114. A 40-year-old man is in cardiac arrest. Your partner is performing CPR. You are attaching the AED when the patient's wife tells you that he has an automatic implanted cardiac defibrillator, an AICD. The AED advises that a shock is indicated. What should you do? Okay, so have you guys heard of these AICDs before? Okay, so just like some people will have a pacemaker to give a signal to their heart when to beat because their own electrical pathways aren't working properly. Sometimes people also have these implanted defibrillators because their heart has a history of falling into a bad rhythm. Some people will have both, a pacemaker as well as an AICD because it's a consistent problem with them. What these things do is that if your heart rhythm reaches an inappropriate rhythm, the same kind of rhythms that an AED would shock for, it works the same way essentially, but instead of an externally applied shock, it is internal. It's close enough to the heart, it's implanted within the chest wall, kind of up over here usually. You can see it sticking out. And it sends a small shock to the heart that's supposed to do the exact same thing that an AED would do from the outside. It can be smaller because it's internal, and so it doesn't have to go through as much extra stuff. It's just wired slightly differently, but like I said, same exact result. If a patient has an AICD implanted in their chest and they're still in VFib, is their AICD working properly? No. Okay. Based on that, you would treat them like you would treat any other patient who requires CPR and AED interventions. So having said that, which of these things would you call the correct answer? C. If the AED tells you to shock your patient, you shock your patient. Because that's sometimes the system the AED has. That's why it's saying up to 3 shocks. It's not saying 3 consecutively, but most AEDs will actually, like, they'll tell you as it's running. It has a little timer on it, and it'll shock, and it'll analyze and then it'll shock, and then depending on what's happening, it'll either tell you immediately go back to CPR or it'll analyze again. Usually it'll tell you to do 2 more minutes of CPR, and then it'll analyze again and shock again and whatever. It has its rhythm. But frankly, you just look at all the others and they're incorrect. If a shock is indicated, you have to shock your patient. Yes, defibrillation externally will damage the patient's AICD more likely than not. Because of the location that it's in their chest wall, the shock is probably going to be going through their AICD, and you just ruin a piece of equipment. However, it's not working anyway. It's not helping your patient, and so you can't use that as an excuse. If you're weighing in the balance your patient's life versus, a $12,000 little chip in their chest, patient's life comes first. Their doctor may not like it. Their insurance company may grumble while they're paying up, but that is the case. That's what happens. You have to do it. You can't not deliver a shock when you're supposed to deliver a shock. B is not, wrong. It's just not really correct either. If the AED tells you to shock, you shock. If you called medical control, they would say, yeah, go ahead and defibrillate. That's what the AED is telling you. So it's sort of, it's not that it would be bad to call medical control. It's just totally not necessary. It doesn't fit with what you really have to be doing at that point. And then D is wrong because it doesn't include a shock. And you have to shock your patient. Number 115. A 58-year-old male presents with confusion, right-sided weakness, and slurred speech. As your partner is applying oxygen, it is most important for you to what? Okay, so confusion, right-sided weakness, and slurred speech. At this point, what should you be thinking is wrong with your patient? Stroke. What points out specifically stroke versus anything else that might cause altered mental status? Right-sided, slurred speech as well, but also especially that right-sided weakness. So we talked about that, the stroke scale. Remember FAST? We talked about it, I guess, on Friday. F is facial droop, so you're kind of looking at their face to see if one side it looks droopy compared to the other. That's a good sign that they're not having good muscular control on that side, which would point clearly to a stroke. A is arms, remember? Holding the arms in front of them, seeing if one arm, again, has poor muscle control compared to the other, or if it's really weak compared to the other. F is speech. We already know that one's there. So slurred speech and right-sided weakness, that's your A and your S, right? You ask them to say something, and if they're slurring, again, poor muscle control on one side, or just in general, is often caused by a stroke. What does the T in FAST stand for? Time. Okay? Based on that, the answer that's correct here is D. Why would the answer be D? Okay, so time is important. You ask his wife when she noticed the symptoms because, remember, there's drugs that you can give to help reverse a stroke within a certain window of time. For the most part, that window of time is 3 hours from the time that you notice symptoms, or rather from the last time they were seen to be normal. So what that means is that if you have a patient, say you're called out to see them at 8 o'clock on Saturday morning, and their daughter came by, they wanted to kind of check in on them, and the daughter notices that they have signs that look like they might have had a stroke. They're weak, they're slurring their words, they're totally out of it. So she calls you in. It's 8 o'clock on a Saturday morning. Now, if the last person to see your patient saw them at 9 o'clock the previous night, her neighbor next door had, returned a pie pan. I'm making this up as I go. How long of a window of time has it been at that point? Yeah, like from 9 p.m. that night to 8 a.m. the next morning. Okay, so even if the stroke only happened at 7:30 on that Saturday morning, all we know is the window that we have. We have to assume that it has been 11 hours since her stroke, because we don't have anything else to judge it by, and she can't tell us necessarily. We're not really going to trust that judgment anyway, because they're probably confused, altered mental status. So you have to take it for what it is, and you want to hit it within that window. That's why you really have to find out as soon as possible, when's the last time you saw your husband behaving normally? When did you start to notice these symptoms? Try to narrow down and get a good, accurate time so that then you can talk to the doctors and they can try to get those drugs in them as quickly as possible. All of the others, let's see, C is out because we're already thinking stroke. We're not thinking about a diabetic emergency. B is a thing to do. It's not a bad thing to do, but it doesn't take precedence when we're talking about this immediate treatment right here. And likewise, A isn't bad. You want to get medications, you want to get vital signs with any patient. But since time is such an issue in a stroke scenario, what they're trying to test with a question like this is, do you know how big of an issue time is? Do you know how to deal with a stroke specifically, not just a patient in general? Does that make sense? Okay. Number 116. Immediately after being dispatched to a residence at 1455 Mason Avenue for an elderly patient with diabetic complications, what should you do? Okay, so your dispatcher has told you, sorry, this thing keeps messing up. Your dispatcher has told you a location, has told you basic information about this patient, right? Elderly patient, that's something, and has told you a little bit of what seems to be going on. That's all you know at this point. Of these options, which one seems like the best thing you should do next? C? Ask the dispatcher if the patient is conscious or unconscious. Okay, that would be good. C is a good possible. Let's look at all of them, okay? D, I would take out immediately. Why? There's nothing to point to needing a secure scene, right? It's one patient with diabetic complications, so they're probably confused. Knowing what we know about diabetic issues, we can probably assume some sort of altered mental status. Along with that, sometimes comes some aggression, things like that. But you wouldn't want to call the police ahead of time and say, hey, I need you to go to this residence and clear the house and scare this little old lady, just in case. That doesn't fit at all what's happening. So definitely not D. We already said C is not a bad idea. What about B? Ask the dispatcher to obtain a medical history. Oh yeah, so they've already told you diabetic complications, right? That's a good start. So they've told you something. You can't ask the dispatcher to call that caller back and say, hey, tell me more information. That's not their job. It's your job when you get to the scene. So B's out. And then A, confirm with dispatch that you received the call information. So this would literally mean saying, okay, dispatcher, I'm going to go to 1455 Mason Avenue, and I have an elderly patient with diabetic complications. Is that correct? Okay. Would that be a good thing to do?
No.
Yes.
Oh, yes.
It would never hurt to check and make sure that you have accurate information, especially when it's something as specific as a residence and an address. You want to make sure you have that address right before you go up and ring the doorbell with like lights and all that cool stuff going on. You want to know what you're going into, so you want to make sure you heard them correctly. Maybe you thought they said diabetic complications and they actually said something different. So the more prepared you can be, the better. And it would be really good to repeat back to them what they just said so that you know that you heard them. Did you have a question? Okay, so yeah, that's kind of a side note, but usually on an ambulance you will have, at the minimum, you'll have basically a giant map of your city in a book.
Yeah, that's what they had.
Yeah. Some of the, I think they're called a Mapsco. Some places have those still. A lot of places do have GPSs. I've known some drivers who will take their personal GPSs to work if they know they're going to be driving a lot that day and put them right where you'd put a normal GPS, but put it in the ambulance. You can potentially use your phone with the concern that you don't want to use your phone in a dangerous way. Just, you know what I mean? You wouldn't want to be using GPS in a way that would somehow cause you to not have full attention to the road, like with any GPS. So most of the county-related or fire-related services that I have seen actually have GPS as part of the whole kit that you use. Like it's on their laptop when you're going somewhere. You've got the laptop and that has GPS and everything, and it shows you exactly where to go. Private or smaller companies will sometimes have other options. So when I was driving for a private company, I often did pull out my phone, type in the address before we even really got into the ambulance, like as we were running out there, to make sure I kind of knew where I was going. And then once we got close, I would ask my partner to help make sure that I was navigating correctly. So because I wanted to pull up to the correct location and not make wrong turns. So yeah, you could potentially use a GPS.
Would you get in trouble if, like, you went to the wrong address and that caused time delay?
Potentially. Yes, because you're not accurately carrying out your job. Sometimes it's a bigger deal than others. I mean, to some degree, it can't always be your fault if there's delays in time. But if that delay comes from you being sloppy or not checking something properly, then it turns into one of those issues of, like, you didn't do your job. But getting back to this question, we definitely cleared out B and D. The only choices left were A and C. Which one is probably more important? A. A you'd want to do with every single call for sure. You'd want to repeat back and make sure, confirm that you got the correct information from your dispatcher. C isn't wrong, it's just A is better. Number 117. You are dispatched to a local nursery for a 39-year-old female who is sick, quote unquote. When you arrive, you find the patient lying on the floor. She is semi-conscious, has copious amounts of saliva coming from her mouth, and is incontinent of urine. You quickly feel her pulse and note that it is very slow. Initial management for this patient should include what? Okay. Yes, the answer choices I heard y'all say mostly were B, and that is correct. Thoroughly suctioning her oropharynx. They give a real clear indication of this in the question when they're talking about those copious amounts of saliva. So you're immediately thinking, okay, airway complication. And airway is high enough on the list that, yeah, you want to deal with that. Why wouldn't you want to give BVM ventilations first, initially?
Because the saliva is blocking their airways.
Yeah, because she probably has a lot of saliva in her airway. BVM ventilations would totally be a good idea. It's just, when we're looking at literally the first thing you should do, it's not the very first thing. You got to get that airway open first. Do we ever perform a rapid medical assessment? No, we have a rapid trauma assessment, but rapid medical assessment, we've never used those words in that phrase like that. It's sort of trying to trick you there. And would you ever, I mean, D doesn't even, I'm just, request a paramedic to give a drug. That's totally outside of your scope of what you would ever do. You won't really have that type of answer choice on the real test because they know that's not the kind of thing that you would actually ever do. Looking at this patient real quick before we move on, let's try to come up with a diagnosis of what might have happened to her. Looking at what you see in terms of signs, what can you think of that would point to this presentation? The one thing that really stands out to me is the incontinent of urine, which means essentially that she wet herself, right? What does that mean? She lost control of her body. Okay?
Probably
Say it louder. Seizure. Yes. She lost control of her muscles. She had a seizure, is probably what happened. The test is not going to require you to think that hard into it, but I want you to recognize it's giving you a really clear seizure presentation. Specifically, she's in the what stage? Starts with a P. Postictal, right. She's already had her seizure. Whenever they use these quotation marks of like sick, it's a real good indicator that it's probably something that you know. It just kind of is in general saying somebody's acting weird. But they usually are pointing to a very specific thing that you know. And they're going to give you signs and symptoms for something that you can identify. Lying on the floor, semi-conscious, incontinent of urine, all of those things kind of point to coming out of her seizure, that she lost control of herself. Also, the very slow pulse is a good indicator, that postictal phase. So just wanted y'all to be able to kind of recognize that. Number 118. You are caring for a 25-year-old female with acute left lower quadrant pain. She is conscious and alert and in obvious pain. Her blood pressure is 110/70, pulse is 100 beats per minute and regular, and respirations are 24 and unlabored. In addition to administering oxygen, what should you do? Yes, the correct answer is D. Put her in a comfortable position. Do we ever deal with Motrin? No. Do we ever give a patient anything to drink by mouth? No. The only things we ever give by mouth are activated charcoal and oral glucose. I guess you could say oxygen is by mouth, but in terms of things that they're supposed to swallow, it's only ever those. Definitely not water. And y'all remember what Trendelenburg position is? It's the position you use if somebody you suspect is in shock. So lying supine, legs elevated. And that's not really necessary here. Her blood pressure is fine, and there's nothing to point to that's required. So just put her in a comfortable position is good enough. Number 119. When assessing a 62-year-old female with crushing chest pressure, you note that her pulse is rapid and irregular. In addition to administering oxygen, what should you do? So going down these answer choices, do you ever apply cardiac monitors in the field to observe a cardiac rhythm? That is totally outside your scope of practice. In the ER, you may have practiced putting on like the 4-lead or the 12-lead EKG, but you don't have that out on an ambulance, and you certainly aren't expected to use that out there. You do have a 4-lead, I won't say that, but you're not expected to know how her cardiac rhythm is supposed to look based on like the jigs and jags on the sheet. That's above your pay grade. Transport at once and consider requesting a paramedic unit. Why would you maybe want to request a paramedic unit? She might be having a heart attack, and what can a paramedic do for her that you cannot? Yeah, lots of stuff. Start an IV, give drugs. Definitely, they can do more for a heart attack than you can. Document your findings and perform a detailed assessment. Exactly. It's not bad, but it's not really necessary. You should always document your findings. The key here, though, is a detailed assessment. That's based on what's happening. You should be expecting that something's about to go bad real fast, and maybe a detailed assessment isn't the best way to go right now. So I would not say C. And then D, conclude that the irregular pulse is normal based on her age. Should you ever make blanket assumptions like that? That, oh, well, that's just normal for her because she's old, or because she's diabetic or pregnant or anything. I mean, should you just assume that something is normal for a certain patient without verifying it? No. Every patient does have their own version of what's normal. Every patient has their own typical blood pressure and things like that. But you can't just assume that, oh, she's old and that's why she's messed up. So definitely not D. The only really good choice here is B. Number 120. During your assessment of a 50-year-old male who was found unconscious in an alley, you note that he has slow, shallow respirations, significant bradycardia, perioral cyanosis, and pinpoint pupils. As your partner begins assisting the patient's ventilations, he directs your attention to the patient's arms, which have multiple needle tracks on them. This patient's clinical presentation is most consistent with what? Okay, the answer is a heroin overdose. I want to go through, because it's a long question, so I want to go through why the others are incorrect. First off, alcohol intoxication. Is there anything that points to alcohol intoxication? Slow, shallow respirations would, as well as bradycardia, because alcohol does depress the nervous system. So slowing those things down could potentially point to alcohol. However, what points away from alcohol? Pretty clearly. Pinpoint pupils is a classic sign of narcotics overdose, barbiturate overdose, which heroin is one of those. Also, the needle tracks are an additional kind of point towards heroin. Be careful, those could be in there as a red herring, as something to kind of distract your attention. We've had questions like that before where they put in an extra sign that doesn't really fit the question. But it does, I mean, in this case, it does seem to kind of confirm what you're already expecting. A closed head injury, why do we know that one is absolutely not true? Because, I mean, even though, yes, closed head injury could cause unconsciousness, bradycardia, slow respirations. Okay, we don't know if they found any trauma. Yes, that's the big thing. Their pupils would be dilated. Closed head injury, concussion, those almost always, well, pretty much almost always have either completely dilated pupils or will have one small and one large. Is also a classic sign of some sort of head trauma. You wouldn't see pinpoint, though. Definitely not in a closed head injury. And an overdose of Valium, again, it's not going to point towards these specific things. Those needle tracks are really what's kind of helping swing you towards heroin, knowing this presentation and knowing that it's going to be something that depresses the central nervous system, like this. Do y'all know what perioral cyanosis is? What does that mean? Yeah, so cyanosis is that blue coloring of the skin. Perioral means around the mouth. So if you see, remember, peri as in around and oral, you know what oral is. And that's also a classic sign of heroin overdose. So all of it together points towards A. Number 121. While assisting an advanced life support ambulance crew, you are accidentally stuck with an IV needle. What should you do? A says immerse your wound in an alcohol-based solution. It's not good enough, right? You were stuck with a needle. That alcohol-based solution is only going to get to what it can actually see, or rather what it can touch. So anything on the surface, most of it's going to be killed. But no guarantees about like what went actually all the way into your finger or wherever it stuck you. I guess it doesn't say. B, immediately report the incident to your supervisor. Yeah, good solid choice. C, get immunized against hepatitis as soon as possible. Jump into conclusions. For one thing, you should already be immunized against hepatitis. You guys certainly should against B. That's, I think, a school requirement. A, pretty much if you're a healthcare provider, you need to have a hepatitis A vaccine. I don't know that y'all had to get them before taking this class, but most of the workplaces you might end up in, medical-wise, would probably require that vaccine. And C, there is no vaccine for it. So getting immunized against hepatitis, if you're not already immunized, it still is jumping the shark a little bit. It's not necessary right now. D, discontinue patient care and seek medical attention. It's going a little overboard. Think of it logically. You're assisting in an ALS crew. So let's say you have a patient who is having a heart attack because it's ALS. So it's not something you're dealing with. It's something higher level. You're assisting a paramedic and your patient has a heart attack and they're needing you to deliver compressions while one of them does like BVMs over an intubation tube and somebody else is starting IVs. Well, in the process of getting compressions, your hand gets grazed by the IV needle after it's been used on the patient. Maybe it didn't work or something. Should you just stop doing compressions because you got stuck with the IV needle? No. Discontinuing patient care is not going to be your best choice. I know we say that your own personal safety is paramount, and it is, but in a case like this, stopping caring for your patient isn't going to help you at all, really. It's not going to make you suddenly well again, and there's really no way that you can, I know it says seek medical attention, but there's really no way you can treat yourself at all quickly. You do want to report the incident. You do probably want to get checked out. I'm sure your supervisor or your company is going to have a real careful regimen for what happens at that point, but you don't discontinue patient care just because this has happened. Number 122. You respond to a college campus for a young male who is, quote, acting strange. After law enforcement has secured the scene, you enter the patient's dorm room and find him sitting on the edge of the bed. He appears agitated. As you approach him, you note that he has dried blood around both nostrils. He is breathing adequately, has a rapid irregular pulse, and his blood pressure is 200/110. Treatment for this patient includes what? Okay, yes, D is correct. Again, A is going to be incorrect. Anything that when you're requesting a paramedic to administer a medication that you don't know, never going to be the correct answer. Do you need to use a BVM on him?
No.
Because he's breathing adequately. So right there, that's not necessarily. C, ask law enforcement to place handcuffs on the patient. The scene is secure. Asking them to place handcuffs is a little bit much when all he's doing is sitting there. He appears agitated, so you want to be careful, but don't assume that he has to be handcuffed before you can get close to him. D is the good answer, attempting to calm him, being non-threatening, things like that, and then giving him oxygen if he'll take it. Based on what's happening with this patient, with what you see as a presentation, do you have any ideas about what's actually going on with him? He has a super high blood pressure, right?
Yeah.
Okay. I mean, there's a lot we don't know, so it's hard to give a specific diagnosis, but that super high blood pressure, that would probably account for the dried blood around both nostrils. Super high blood pressure in the head, all those little capillaries that are in the nose could burst. There's just too much pressure for them to handle, so that would make sense. Rapid regular pulse, we don't really know, so it's either a heart thing, or maybe we don't know enough to say this, maybe he had an ischemic stroke where he's got a clot in the brain, and so sometimes the heart will compensate by raising its blood pressure in an effort to try to get blood up towards the brain. So you are going to see elevated blood pressure in patients with a stroke. So maybe he overdosed on some drug that you don't even know about. There's a lot of things that you're not sure of at this point. It's good to start thinking of maybe what could be going wrong. But out of these choices, really D is the only thing that makes any sense based on what you know how to do for a patient. Nearly done, you guys. Number 123. After administering 0.3 milliliters of epinephrine to a 22-year-old female with an allergic reaction, you note improvement in her breathing and dissipation of her hives. However, she is still anxious and tachycardic. What should you do? Again, we don't give epinephrine from a vial. So instead of that 0.3 milliliters of epinephrine 1 to 1,000, put after administering an EpiPen. And go with the question from there. Okay, so going down the choices. Well, actually, let's look at the question first. She was having an allergic reaction. We can assume anaphylactic because they gave, or the question implies or says that you gave epi. You note improvement in her breathing and dissipation of her hives, which are two classic things related to anaphylaxis. However, she's still anxious and tachycardic. Okay, so at this point, does she need more epinephrine? No. Excuse me. A patient who has lost the anaphylactic side of the reaction, who that's already been kind of dealt with, you don't keep giving epi to. So the breathing difficulty and the hives, which like the raised bumps, itchy, whatever, those have gone away. Those are classic signs of anaphylaxis. And so she doesn't need more epi just for whatever else is still going on. If we still saw problems with her breathing or things like that, then maybe there'd be an excuse to give more. Otherwise, A and D are both wrong. D is especially wrong because, well, for one thing, you guys can never give a half dose, right? If the full dose is 0.3 milliliters, you can't give a half of an EpiPen. Even if she had 2 EpiPens on her, you wouldn't be able to just somehow give half of the dose that was inside of one. Between B and C, does she look like she's having a severe reaction to the epinephrine? Okay. For one thing, epinephrine is something that your body produces. So your body isn't going to be having a reaction to the epinephrine. Your body, by definition, cannot be allergic to epinephrine. It can be allergic to the other things that are in an EpiPen to kind of help with the delivery system. So that's why you do have to be careful. It's still a contraindication. But there's no signs of an additional reaction happening. In fact, those main signs of the reaction have gone away. Based on that, C is the only good answer. And it does make sense. Epinephrine, what does it do? It constricts those blood vessels, raises the heart rate, raises blood pressure. It would make sense that you're going to still be seeing some of these signs after you give her epinephrine. Does that make sense? Number 124. You have been dispatched to a nearby bar where a man has been stabbed. As you pull up in front of the bar, a man in an apron yells that he's the bartender and that the crazy guy inside has a knife. What should you do? C. This is one of those super easy questions where your own safety comes first. You do not take lead in terms of trying to secure a scene, ever. Number 125. A 28-year-old female patient is found to be responsive to verbal stimuli only. Her roommate states that she was recently diagnosed with type 1 diabetes and has had difficulty controlling her blood sugar level. She further tells you that the patient has been urinating excessively and has progressively worsened over the last 24 to 36 hours. On the basis of this patient's clinical presentation, what should you suspect? So, y'all remember the difference between type 1 and type 2 diabetes? Type 1 is insulin dependent. Their body does not produce insulin or, really doesn't produce insulin. It usually stops at an early age. And type 2 diabetes is where their body produces insulin but won't properly use it anymore. It doesn't have the same effect that it used to, so they have to take pills to control their blood sugar from the other side. This patient has type 1 diabetes. We also know she's had difficulty controlling her blood sugar level. So we're going to assume that whatever the answer choice is, it has to do with blood sugar either being too high or too low. What do we know that might tip our idea one way or another in terms of too high or too low? Okay, so urinating excessively, what does that point to? Okay, so your patient could be dehydrated, but I guess in terms of a diabetic emergency, does that tell you anything about whether her blood sugar is too high or too low? Does that point one way or another? Too high. Yes. So remember, when somebody has undiagnosed diabetes, the things that you will see in them, or if they have untreated diabetes, you will see polyuria, which is excessive urination, polydipsia, which is excessive thirst, and polyphagia, which is excessive eating. The reason for that is what your body is trying to do. So if you have diabetes, type 1 diabetes specifically, and your body doesn't produce insulin anymore. So now insulin was sort of like the key that unlocks the cells of the body to allow glucose to pass through. So there is no longer any key and the glucose can't properly get into the cells, right? That is called hyperglycemia because you have a whole lot of blood glucose running around in the blood and no way for it to get in the cells. Okay, so your body senses that there's a massive amount of glucose in the blood, and it tries to deal with that, it tries to compensate. So it says, okay, we need more water. So you're going to start drinking a lot because it's trying to use osmosis to kind of balance out, trying to get more water in so it can sort of dilute all of the extra glucose that's in your blood. It's really hoping to kind of get rid of some of it by making there more water so like the proportions equal out. If you're drinking a lot, you're also going to be urinating a lot because your body is trying to get rid of all this extra water and all this extra stuff. Your kidneys are working in overdrive to try to get rid of everything that your body now has inside of it. It has a lot of water and a lot of glucose. You're going to be eating a lot because even with all of this glucose running around inside your bloodstream, the cells are still starving. The cells still aren't getting the glucose they need. So they're sending signals to your brain to Eat more, eat more. We need glucose. We're hungry, we're starving, eat more. And so you eat more glucose, which can't get into the cells, so it goes into the bloodstream. So the blood gets more glucose in it, which makes you have to drink more. And once you've drunk more, you have to pee more. And this whole cycle is just continuing itself. Because the body is compensating for all these different things in different ways, and it can't actually fix the main problem, which is there is no insulin, there is no way for the glucose to get inside the cells and do work. So, that excessive urinating is a classic sign of hyperglycemia. The body is trying to get rid of excess blood and excess glucose, trying to balance out, and it just can't. Side note, diabetes, like official name, is called diabetes mellitus. Let me see if I can write that for y'all on this slide real quick. Yeah, there you go. Looks like, I swear my handwriting is better than this most of the time. It looks like I have the handwriting of a child. I'll write the other part down here. Okay, diabetes mellitus is the actual name of it from a scientific standpoint. Who in here has studied Spanish? What is the Spanish word for honey? Okay, so Spanish is a Latin language, or has roots in Latin, and a lot of medical stuff has roots in Latin. So what do we see as kind of a common thread between those two words? Yeah, so like this little part kind of has the same root as this, mel and miel, right? The way people used to diagnose diabetes is because their pee was sweet. It's literally talking about sweetness in the actual scientific name, because they didn't have fancy ways of checking the blood. But what they could tell is that all this extra glucose was coming out in the pee, and so it's diabetes mellitus. It's talking about the extra sugar. They would taste it. And they wouldn't like drink it like a glass of iced tea, but that's how they diagnosed it. They would taste it. The doctor. I mean, medicine was different. Like we're talking like hundreds, maybe thousands, or at least 1,000 years ago. This is like, sorry. No, not necessarily. Pee is actually sterile when it comes out of you. I wouldn't suggest drinking it, but it's a sterile liquid. So, all of this being said, that's probably way more information than you ever wanted to know about diabetes, but now you do. Hopefully you understand it a little bit better. Hopefully it sticks with you. You will never again forget hyperglycemia and the fact that it makes you pee, and your pee is sweet. Right? So, how do I close this out? Okay, so what we're looking at is hyperglycemia. The only choice then that fits is A, right? Another thing, kind of side note, that points towards hyperglycemia instead of hypoglycemia is, remember, if we look at the range of acceptable blood sugar levels in a person, that range is 80 to 120. The amount of room you have to drop before you hit zero is very small compared to the amount of room you have to grow, because numbers go on to infinity technically, and you can't have negative blood sugar. So if your blood sugar is supposed to be in the range of 80 to 120, you have 80 points to deal with, and that means that hypoglycemia develops very quickly because you just have such a small range of numbers. So if your blood sugar is supposed to be, say, 100 and it is 40, that is a huge difference in terms of how they're going to act. If their blood sugar is at 40, they're having a lot of problems. If their blood sugar is supposed to be 100 and we go 60 in the other direction to 160, they're going to be almost entirely normal. You're probably not going to even know. 160 is what you have after you have a really big meal or drink a huge Coke. It's not going to be affecting them at all. To see changes as far as hyperglycemia, you're looking at numbers that are like 300, 400, 800. You're going to be seeing those numbers get higher and higher and higher to have problems. So what that tells you is, you look at this over the last 24 to 36 hours, hyperglycemia has a slow onset. Hypoglycemia, because of the small range of numbers you have to work with, has a very rapid onset. You wouldn't see this over 24 or 36 hours. You'd be seeing it over like 2 hours, or even less time than that. That's another thing to indicate that it's hyperglycemia instead of hypoglycemia. Moving on. All the diabetic information. You are transporting a 49-year-old male with tearing abdominal pain. You are approximately 30 miles away from the closest hospital. During your ongoing assessment, you determined that the patient's condition has deteriorated significantly. What should you do? Okay, so let's look at these answer choices. Begin ventilatory assistance with a BVM. Good or bad? I mean, does that seem like it would fit what you have to do? It wouldn't be bad. I mean, it wouldn't be a wrong thing. We don't know anything about their breathing, but I guess we could generally say that breathing is important, and you might need to give oxygen. So it's not a bad answer. It could potentially be the best answer depending what else is out here. B, immediately perform a detailed physical examination. Sorry, what? Yeah, it's not going to help him. This patient is critical and getting worse, deteriorating significantly. A detailed physical examination isn't actually doing anything. It's like, oh, well, you're about to die. Well, let me just look really carefully at your chest here so we can figure out why you're about to die. Like, they're still going to die. You're not helping. So definitely not B. C, continue transporting and alert the receiving hospital.
What if you just stop transporting?
Yeah, okay, so you wouldn't stop transporting. So continue is like, duh. Alert the receiving hospital, again, isn't a bad thing to do. So we're kind of having some answers that are like, sure. Like with a question mark, maybe those are the right things to do. Let's move on to D. Consider requesting a rendezvous with an ALS unit, Advanced Life Support Unit.
That's right, isn't it?
That is right. D would be the correct answer. The big clue here is, first off, tearing abdominal pain. What is happening with this patient? Just based on that, you should be able to come up with something. We talked about it, I think, on Friday, briefly. Your patient has an abdominal aorta that is potentially about to rupture. Okay? We don't know about the pulsating. That's the sign that we talked about on Friday, the fact that you're going to see that pulsating mass near the umbilicus. But what's happening here is that tearing feeling is literally the feeling of the layers of the abdominal aorta wall tearing away from each other. Remember, the abdominal aorta carries a lot of the blood. Essentially, it carries all the blood. They didn't go up towards the head. It's carrying everything else downwards. And so it's got to be a big vessel. It's got to have thick walls. And the layers that make up those walls are tearing away from each other. For whatever reason, it's getting really, really weak around there. And that's what an aneurysm is. It's like the weak spot in a balloon where it bulges up where it's not supposed to. The problem with that is that tearing abdominal pain, that feeling of weakening as those walls are ripping away from each other, can be very shortly followed by actual rupture of this aortic aneurysm, which pretty much leads to death right away. It's a very short amount of time from when the main blood vessel that supports the entire lower part of your body, when that breaks open and when you die. Like, that's a very short amount of time between those two events. Based on that, based on the fact that, okay, this patient is really having trouble, and then they're deteriorating. So it was just tearing abdominal pain. Now it's getting worse. Whatever is going on with them is getting worse. You want to go ahead and get paramedics there because this is way above your pay grade. You want to get somebody who can actually deal with it, hopefully, better than you can, because you're not going to be able to do much. The reason why C wouldn't be the best choice, alert the receiving hospital, you do want to alert them. However, you're 30 miles away from them, which means at the bare minimum, you're 30 minutes away from them, and a lot can happen in 30 minutes. You may be farther than that because you probably have to travel through some amount of like residential or areas where the speed limit is lower than 60. So you may be an hour away from getting to them, 45 minutes, who knows. You don't want to just tell the hospital and keep going. You want to get those paramedics there who can deal with it better than you can. That's why the answer is D. Everyone good on this one? Okay. Remember abdominal aortic aneurysms because we've obviously had several questions on them here. You may have a question about them on your test. And they're very specific, and they will expect you to know what that looks like and what the signs and symptoms for that are. Number 127. A 71-year-old male is semi-conscious following a sudden severe headache. There is vomitus on his face, and he is breathing with slow, shallow respirations. The most appropriate initial airway management for this patient is what? B, suctioning. Because there's vomit on his face, we can probably expect that there's some in his airway. Doesn't tell us that, but be prepared. You're probably going to have to do suctioning in this case. An NPA definitely doesn't fit. There's no reason to indicate that he needs an NPA. A BVM is probably going to have to happen after suctioning. And a non-rebreathing mask wouldn't be as good as a BVM because he's got those slow, shallow respirations, so we cannot assume that he is breathing adequately. He's actually going to need ventilatory assistance. Number 128. This is actually our last question because 129 and 130 are both repeats from earlier in the test. 128. Upon arriving at the scene of a motor vehicle crash, you find a single patient still seated in his car. There are no scene hazards. As you approach the vehicle, you note that the patient is semi-conscious and has a large laceration to his forehead. What should you do first? Yeah, so there's a lot of information in this question, and there's longer answers. It may take a while to read through them, but the actual answer is pretty clear. It's A. You want to direct your partner to apply manual inline support of the patient's head. When we did our practical skills, that was the first step you had to do whenever you suspected spinal injury. Remember, it was a critical fail point, so it's basic. B is incorrect because even though you have a cervical collar on them, you wouldn't do a closed drag. If there's no scene hazards, that means there's no indication that you have to move them rapidly. You can take your time and be careful. Applying a vest-style extrication device wouldn't be a bad idea. However, it doesn't come before manual stabilization of the head. And D, again, it'd be okay potentially after you've manually stabilized the head and the spine. So you could do A, you could do C, you could do D, but you'd have to do A first. And B is completely out of the question. And as I said, remember we went over this, that costovertebral angle. We talked about how that's the angle that your ribs make with your spine. So if that area is hurting, it's your kidneys most likely. I didn't read the whole question because we've gone over it. And 130 we've also gone over. So that's where we'll stop for today.